So if the FDA is going to try to keep pharmacists from being able to prescribe, what's a pharmacy going to do? Make a relationship with a telehealth provider?
I think what you're describing is the tectonic policy implementation value proposition battle of the next 3 to 5 years, frankly, because there's been some open questions that got settled during the pandemic.
Like what?
Can pharmacies bill medical? Are pharmacies willing to schedule patients? Can pharmacies derive a margin from providing services and load balance their labor? Blew all of those things out of the park. Can they adopt? I mean, infusion's a great example. Within 3 to 4 weeks of the opportunity, we had hundreds and hundreds of pharmacies doing infusions. If you'd have said that pre-pandemic, you'd have been like, no way, pharmacies aren't going to get it. It's too hard. It's too weird. It's not in their space. Well, when you have a $400 and $700 opportunity, guess what? You figure it out real quick.
Right.
Right. So those questions are answered. Now it's going to become structurally, what's going to happen with vertical integration? What do the policy battles look like? What is the role of the consumer and the public saying, wait a second, it's safer, more effective, and cheaper for me to go this route versus that route? Why are you preventing me from going this route? I think that's going to be the big theme over the next 3 to 5 years when it comes to the longer arc of community pharmacy.
Do you think there's some correction in there for like nurse practitioners and PAs where they went and they expanded so fast that a lot of them seem to be out of their scope? If you look at, cost of care, they're doing more defensive stuff. They're doing way more tests. They drive up cost in certain cases. Do you think pharmacy is kind of suffering from some of that now, where if there's a limited scope of practice for prescribing for pharmacists, that makes way more sense than just saying, open it up?
I think the nature and culture of pharmacy as our upbringing and our professionals were our own worst enemy when it comes to how do we communicate our value to consumers in the marketplace. And I think it relates to how, and I'm there's great PAs out there, there's great MPs out there. As a trained health economist, I'm all for people leveling up. It just makes sense to do it that way, just from a systems perspective. But if you look at folks that are in sort of these other areas, so you have pharmacists, PAs, MPs, other types of professionals and paraprofessionals. And when you look at services that get covered, when they win policy battles or when they get credentialed or when they get services, what I keep trying to convey to a lot of the folks in my network is, in pharmacy, our natural inclination, and primary care suffered from this, family medicine very much suffered from this. Our natural inclination is to say, we're good at taking care of people, we can keep them healthy over the long run, and we can prevent downstream hospitalizations and whatever else. We bring lots of health and economic value to the system. Okay?
Yep.
Patient-centered medical home was primary care 1967. Nothing really actually changed until the money conversation changed with the Affordable Care Act and some of the antecedents of it. Right?
Yep.
They made the same mistake we're making in pharmacy. Pharmacy's making the same mistake PCPs have been doing for a long time, which is the logical, sane value proposition if you're talking to a centralized system like the UK or Canada or whatever else, right? We have a different type of a system. It is a marketplace of ideas, good or bad. Some of those are good ideas, some of them are bad, but it gets there's a sort of a quasi-marketplace policy battle with agency cost in the US. And you don't win that battle by saying, hey, over the course of 10 or 20 or 50 years, look at how much value I can bring to the system. That doesn't lead to a CPT code that pays $120 for a 99 whatever.
Right.
Because we're on annual budgets, annual legislative cycles, right? We don't have this long-term national strategy that you can actually reinforce on long-term time horizon value. We have fistfights every, annum, right? And so to me, what I've seen in the marketplace, and I think we need to apply in pharmacy, is not, hey, there's a study that says we save dollars 2-to-1 over 5 years. We've done a gazillion of those. Primary care's done a gazillion of those. The way you win the battle is you say, by not letting me do this, people are getting harmed. That's how things get covered. I want access to that Alzheimer's drug. My grandma's getting harmed. My mom's getting harmed by you limiting access to it. Not, here's this great ROI analysis that yada, yada, yada. Those are AMCP dossiers that go out to every country in the world except the US. There's a reason AMCP dossiers, they go to P&T committees, but at the end of the day, this battle's won on people not having access and they feel like they are being harmed or there's risk to them by not getting access to a service. And I see that in Medicaid in a lot of spaces, trust me, right? Where there's all sorts of services that are available that they try to turn them off and advocates say, you're harming my disabled child, or you're harming this, or you're causing risk to people. Those are newspaper articles. Those are successful campaigns. And the crazy part about it, gentlemen, is pharmacy, along with primary care, are probably the two principal providers and conveyors of safety. If you had to pick two providers in your life, or for your mother and father, right, or your son or your daughter, that you want to make sure have their crap together for your safety, it's those two. But yet, we both do a really bad job of saying, if you don't have good access to primary care services and you go have access to pharmacy and pharmacy services where we can actually organize stuff, here's all the bad things that happen to you. We've got to do a better job of that.
So